Okay, so I think we can move on to the next case, for the sake of the time, because we have now 25 minutes left. Fatma, please present. You're presenting, right?
Yes, I'm presenting. Skip this slide. I can, go through the other slides and then let the audience see. So this was a 51-year-old female with KPS 90. She presented in June 2021 with this right middle fossa lesion, which is आगे करें? Which is mainly in the right temporal skull base, and it's extending till the posteriorly till the tent, and laterally till the convexity, and medially till the cavernous sinus, and even in the prepontine and suprasellar cistern. And you can also appreciate here, okay, यहाँ पे भी देख सकते हैं आप, on the top right, the lesion is also extending into the infratemporal fossa, right? So this was a pretty much extensive middle fossa lesion. Can we move to next? So this patient on this scan underwent surgical resection in June 2021. We did a right terional craniotomy and excision. This was the post-op MRI, and where you can appreciate there's a residual lesion near the base of the temporal fossa. Next, please. So there was this lesion which was residual around the skull base. You can identify the enhancement near the infratemporal fossa as well as this medial small component. So the histopathology, yes, you can also appreciate it on the sagittal images. Next, please. So the histopathology for this lesion came out to be atypical meningioma, WHO grade 2, and patient then underwent a gamma knife radiation in September 2021. Next, please. Yes. So this was the scan after gamma knife in 2021. So this scans, it was in July 2023. So the patient was lost to follow-up from 2021 September till July 2023. So in July 2023, you can identify more on the contrast enhancement. Next, please. Yes, so there's a significant interval increase in size of the lesion in the mainly in the infratemporal fossa, as well as some cystic changes with edema in the intracranial component, which was residual. Move to the next, please. Yes, you can very well appreciate that the first there are radiation-related changes in the previous residual lesion, and then there is a progression in the infratemporal fossa and posterior margin along the tent. There's also interval increase. Next, please. Yes, significant edema and mass effect. Yes, please. Next. Yes, similar findings on the coronal images. Yes. So this is the CT scan, which is showing extensive temporal bone erosion on the right side.
Thank you, Fatma. So it's a case where he or the patient underwent the surgical resection and then SRS, and then there is recurrence, right? So the question to the tumor board is, what will be your suggestion? Should we go for another radiation or surgery follow-up? Right, Fatma?
Yes.
We are asking these questions to the tumor board. I think we have Dr. Asim with us, and again we can ask him what are his thoughts for this case, sir, for the atypical meningioma operated ones, had SRS, and with this disease now.
So as far as radiation is concerned, if we look at the management of meningioma particularly, so it all depends upon the grade of the tumor itself. Because meningioma is ranging from grade 1 to grade 3, and the behavior is somewhat different from each variety. So we have, when we are talking about the management itself, the preferred approach is actually the surgical excision as much as possible. And because in certain cases, the only thing that it needed is actually simply the cross-tutor resection, and the only thing after that is required is simply the observation. particularly when we are talking about the role of radiation therapy, it particularly indicated when the tumor is unresectable, or there is a cross-residual disease, particularly when you're talking about the grade 1 or grade 2 meningioma. So regarding the management of grade 2 meningioma, the literature shows that currently the preferred approach is actually the, treating the whole post-operative pad rather than the specific residual disease only, because recently the data shows that is all the meninges, all the this dura that has been involved or meninges that is involved is at risk for recurrences. So particularly talking about in the SRS or the stereotactic radiation therapy in the adjuvant setting, yes, if you can find some institutional practice or some institutional guidelines for role of stereotactic radiation therapy in grade 2 meningioma, but overall the guidelines suggest is actually when you're talking about the different guidelines, it's all suggest actually covering the all the parts of actually the post-operative field within the radiation treatment for providing better local control. So if a tumor is already received radiation therapy or stereotactic radiation therapy, or if it recurs, that's the second question would about the surgical excision. Because as I mentioned, because of the behavior of the meningioma itself, it is very unusual for radiation therapy, particularly when we're talking about the small the low-grade tumor to be completely disappeared by the radiation therapy itself. So that's why whenever there is a recurrence, the first option would be actually the surgical excision. Regarding the role of re-radiation, it depends upon a lot of factors. It depends upon its relationship with the surrounding normal structure, the dose previously received by the patient, and also upon the patient performance status and the current behavior of the tumor itself. So putting all this thing in equation then would actually help to actually decide about the radiation therapy management plan when talking about the recurrent setting. But as I mentioned earlier, all this factor is very important because it is when you're talking about the re-radiation, yes, re-radiation in certain cases can be considered, but by doing re-radiation particularly in the same site, patient, if the normal structure is already, for example, optically increase the risk of radiation related changes, and that's how actually it is also compromises the effectiveness of radiation therapy, because if you are limiting yourself to the critical structure and minimizing your doses to that particular site, you also can increase the chances of actually decrease the chances of local control at particular sites. So that's why it is very important uh, to be very vigilant and better to discuss all these cases, particularly in the recurrent setting, before embarking on any treatment in the multidisciplinary meetings or multidisciplinary tumor board, so that the best or optimal plan can be made accordingly. Thank you.
Thank you. Thank you. Thank you. That was really excellent and very informative, I think, for all of us. I think. Dr. Mazad, what are your thoughts in the recurrent atypical meningiomas? So,
Now, yeah,
yes, sir.
in this case, in this particular case, because this patient was treated with SRS, a very high dose was given, sir, and when on follow-up there was recurrence, certainly surgery would have is the best option which this patient had. Giving further radiation, I think, as Dr. Asim has said, it depends now a lot on the factors, because if the optic chiasma has received a dose of radiation, further radiation to that area is going to give problem to the patient. So in this case, particular case, I would certainly this patient should go to the same institution where she received SRS, so exactly they know that what area was radiated, rather than going to a new center. Nobody would, trained radiation oncologist would not recommend radiation straight away without knowing exactly the fields of SRS. I feel if in this case, the re-radiation would be dangerous. One should not at the moment give her further radiation, and should follow up the patient. If the case comes to when the patient becomes symptomatic and there is no other choice, then a palliative dose of radiation can certainly be given. But I would refrain from radiation at this stage. Just follow this patient because re-radiation can cause her problems.
Okay, thank you, sir. So I think I wanted to ask now Dr. Shumaila and Dr. Shayan's opinion that what critical neurovascular structures you see involved in this lesion, in this pathology. Dr. Shumaila, you can. Yes.
Yes, actually, it is very close to cavernous sinus, and the way it is going through the neural foramina, possibly it seems that as if it is going through foramen ovale. So there are intracranial nerves which have the passage through the same neural foramina and in the cavernous sinus. So this is a very critical field in which all the important nerves which supply to face and orbits and extraocular muscles, so all of them are here. So obviously this is a very critical area, and definitely as Dr. Sab said that should go to the same center where the radiation planning was done so that they can, make a better decision how to approach this patient.
Right. Thank you. Dr. Shayan, if you want to add anything to.
Yes, and it is also very close in approximation with the carotid space as well. So like all the vascular and neurovascular structures and the base in this region are involved by the tumor. So it's a very infiltrative kind of tumor.
Okay, thank you.
Dr. Hassan, I have a question from
Yeah.
Dr. Riaz.
Yeah.
Can you please
Yeah,
go back to first post-op scan? Dr. Riaz, would you suggest doing a redo surgery for the first residual?
Again, was that planned pre-surgical embolization in this case?
No.
No. So I think as a surgeon, this is a very close to the skull base, close to the internal cavernous sinus, and also going into the extracranial portion of the skull base. So it is my opinion that it should be the patient should be sent for the pre-operative embolization. And then because this tumor can be must be a very vascular tumor, because we are not in the mid-cranial fossa, but we are going into the skull base. So in this region, if somebody says, okay, I will remove the maximum tumor safely, so it is necessary that there should be a planning of the pre-operative embolization. Your question was to re-operate after the radiation. I think it would be very difficult after the radiation if you are going to the tumor bed.
Oh, no, sir. No, sir. I was asking for a redo after first surgery for this residual, which you can see in the temporal region.
If it is not radiated, then definitely.
Not radiated.
Yes, definitely a redo surgery can be planned with the pre-operative embolization.
Okay. So do you do pre-op embolization in all the meningiomas, skull base?
You are asking me.
Yes, sir. Yes, sir. I'm just asking because, like, what's the criteria? How do you choose the patient for the pre-op embolization?
We are working in the government sector, and as far as our funds are concerned, so in those patients where the funds available, we always prefer those cases which are the skull based, like the frontal, and sometimes the huge tumor which is adjacent, like the peripheral sign. So we always prefer and arrange the funds, but you know that this is very difficult, and always we prefer to send the patient to AFAN, or if it is poor, then the CHK. Nowadays, it is that there are friends who are doing it free. But again, in the AFAN, particularly in AFAN, it is very costly. at least more than 2 lakhs is required. And in government sector, it is difficult to send every patient with such type of amount freely. So what do you think? This patient needs a good surgical removal with the embolization. We always arrange the funds and send the patients, and we did in many cases like that.
Okay. Thank you.
And if you are not confident that you can remove whole of the tumor,
Yeah.
then I think it is better to send the patient to the center where the services are available and where the skills are available. It is not easy that the tumor, which is intracranial and extracranial like that, you can start removing and also struck with a lot of the vascularity, blood. So it is better to send the patient and prepare the patient, though it is costly, but need to be help the patient.
Right, I agree. So, right. So can I ask also a question to the board? So let's say if we go and take out the tumor intracranial and the extracranial, also the infratemporal fossa, but somehow we left a small residual. So I think I will be asking my question to the radiation oncologist also, that if the field, if the area, the residual is smaller than what you are looking at the moment on your screen, would you consider re-radiation after the surgery if there is a small, or because it's an atypical meningioma, or you would prefer follow up with the serial imaging? And doctor,
Actually, the dose depends what dose the patient initially received. If they have received more than 55 or 60 gray, further radiation in that area is not indicated until unless it's only for palliation, when you think that patient is not going to live for more than 6 months.
Okay.
But in this case, even if it's a small lesion, in re-radiation in that area is not very safe after radical doses. So I would recommend a follow-up on this case at this stage, actually, to be very honest.
Thank you, sir. Good. Any further comments, questions?
So one of the important thing is that when you're talking about the radiation setting, it all depends about your treatment field as well, because dose is very important as mentioned by Dr. Mazhar, and also the other factors that we have discussed previously. But one of the important thing is that if, for example, that's why the important is that whenever we are talking about the re-radiation, it is a challenge. That's the important. That would be the message from my end. So that's why it is very important when we are planning for a patient. It is best to discuss it at its maximum at the initial before embarking on the treatment, because once you have the patient is already got treatment, and when you're talking about the small residual, about the giving the re-radiation, then always there is a question arises from an engine point of view, because there is a difference of opinion. There are some institute offer radiation therapy, some institute actually defer radiation therapy, because that's the issue associated with radiation, because radiation is always a challenging thing because of its toxicity profile as compared to from the live patient, radiation live patient. But if the treatment, if the recurrence is a site distant from the previous radiation site, then obviously radiation therapy can be considered safely because the area is not exposed. But if you're talking about the area that is actually already exposed, and particularly the organ critical structure that has actually already received radiation therapy, then definitely is a challenge, or it needs to be looked after further. Because we are not only the organ at risk, because brain itself is an organ at risk here, because increasing the doses, you increase the risk of radiation necrosis, and also because this patient also has a component of infratemporal fossa as well. We don't know about the treatment, the previous radiation treatment field, whether it is was covered previously or not, because if it is a gross rotary section, then I agree with the Dr. Mazad, and this patient only required the required close observation, nothing else. But if it is a significant disease and will have seen the behavior of the tumor itself, then definitely this patient needs some form of treatment. Otherwise, because meningioma is a slow growing tumor, it may take about some time to actually, but providing bus it directly affects the patient quality of life as well. So that thing need to be discussed with the patient in detail about whether to before embarking on the radiation, because radiation is always a challenging thing from radiation.
Has atypical meningioma completely resected, would you radiate then? Or second scenario, when you have atypical meningioma, questionable positive margins, when would you radiate, so that at least everybody's clear? Because as Dr. Asim said, it's some one-time use tool, so you use it wisely. When is the right time in an atypical meningioma?
So the rule.
Well, I would, sorry. Yeah, okay, you go ahead.
Yes, sir, please proceed.
Actually, I personally would not re-radiate if the patient already had received
For the sake of
first time
participants.
Okay, first time when surgery is done, we start radiation within 6 weeks of surgery. That's the optimum time. Not
So regarding the role of radiation therapy in atypical meningioma in a treatment type patient is actually is something that because there is two observational study. One is from the RTOG that have classified, but it is an observational study in which they have defined the patient with cross-total resection as a intermediate group, and if the patient has a recurrent.
We dropped Dr. We lost Dr. Asim, but we got the point. Fatma, am I audible?
Yes, we did.
yeah.
Yes, you are clearly.
Right. So there is a question in the chat also. Dr. Saad is asking about the approach to the infratemporal component of the tumor. So I think that will also get like into the surgical discussion. Maybe we can also discuss later. But one of the ways to involve also your head and neck surgeons with you. But it depends. Like I don't want to go into that as a discussion right now. And Dr. Zishan Ahmed is asking if is there size concern for post-op radiation therapy for a tumor left behind? Size does. So I think what they want to ask the tumor left behind, the size does matter for the post-op radiation or not? Dr. Mazhar?
Yeah, certainly. If the patient has not received radiation before, then if there is a disease left behind, considering all the factors as well, like age, performance status, and all, if patient is in good performance status, one should radiate the leftover the tumor because it's going to grow again.
Okay, thank you. Dr. Adnan, Dr. Mazhar, and Dr. Riaz, if we do not have any further comments or questions, maybe we can end our session and then what are your thoughts? Any closing remarks?
I think it's a good forum, and we should bring up cases, treated cases as well for the teaching, and new cases as well in which there is which are difficult cases, so we can get opinion of all the experts. And it's always better to have multidisciplinary clinics, which helps a lot and gives a lot of reassurance to the patient as well as to the treating physicians as well.
Thank you. Dr. Adnan.
I'm sorry. Yeah, can you hear me now?
Yes,
so
sir.
I always say these are always very good. Our practices at AKU had been multidisciplinary, and I think that has greatly benefited the patients, the physicians, because sometimes we get stumbled. So it's always very important to have experts around you. And time and again, our decisions have been changed when we discuss. So I think communication is the key. And discussing these cases in this forum only clarifies things, not only for us, but also the upcoming trainees. So I think we should spread the word, and we would like more people to attend these sessions. And in fact, perhaps maybe if we have a case which involves a center, say for instance, we had a gamma knife case this time, so we would extend invitations to them so that we can have their perspective, because talking amongst ourselves will not change it unless we involve the people who are practicing things and find out what are their challenges. Why did they radiate a person without a biopsy? What are their concepts? And that is the only way we will make a headway in improving the care of these patients.
That's so true. So thank you very much. Thank you all for joining us today. And
Thank you very much.
Thank you. And I look forward to seeing you all in the next session. And take care and enjoy your weekend.
Thank you so much. Bye. Allah Hafiz.
Thank you,
Thank you,
Allah.
Dr.